Hello, everyone. It's 2 o'clock, so we'd like to get started, if that's okay. Hello, everybody. My name is Allison Corder. I am the Director of Business Development for New Cortland and the liaison for Germantown Home Nursing Home. Welcome to a discussion on redefining the future of healthcare transitions hosted by New Cortland, Germantown Home, a proud member of the New Cortland community, and the New Cortland Center for Transitions in Health under the direction of Dr. Mary Naylor, Professor of Gerontology at the School of Nursing at University of Pennsylvania, a board member at New Cortland, and Chief Architect of the Transitional Care Model. We are so excited today to have such fabulous speakers for our discussion. First is Dr. Mary Schuler, Medical Director for New Cortland. Dr. Schuler has extensive experience caring for geriatric patients in outpatient, hospital, rehab, and residential settings. We have Ashley Ritter, nurse practitioner for New Cortland and a geriatric nurse practitioner and postdoctoral fellow in the National Clinician Scholars Program at the University of Pennsylvania. Ashley has worked with older adults across the spectrum of care settings, from ICU to home. Lastly, we have Dr. Mark Tolles, Associate Professor at the University of North Carolina at Chapel Hill School of Nursing. Dr. Tolles is a nationally recognized scholar in the transition from skilled nursing facility to home. In his current research, Dr. Tolles continues to develop and test Connect Home, a transitional care intervention for older adults as they transition from skilled nursing facilities to home. Before we get started, I would like to remind everyone to please place yourself on mute. You might be muted already until the end of the presentation. We will do Q&A at the end, so please place your questions in the chat box and we will review at the end of the presentation. The presentation will be recorded and posted on the New Cortland and New Cortland Center for Transitions in Health website. So with that, we will get started.
Thanks everybody for being with us today to talk about transitions in health with a really stellar team. I'm thrilled to be here. And I think a good place to start is, what is a transition in care? What do we mean by transitions? Transitions can refer to changes in providers, transitions in one care setting to another, or even changes within one level of care, let's say from a medical unit to an ICU. But you can also have transitions across health status, so from a stable health status to one of acute illness. These transitions are very common for people that are experiencing health crises, but also within the process of normal aging. Transitional care focuses on these transitions by focusing on the coordination of care to maintain continuity and the well-being of patients as they encounter these transitions. Transitional care takes into consideration a patient's goals and preferences, the clinical status of an individual to make a holistic plan of care. It includes logistical arrangements as well as education of the patient and family to be able to achieve the goals in the setting that this individual will now be in, whether that be a disease state or a physical setting, and what's going to be needed next. And it really requires coordination among health professionals that are involved in the teams required to support an individual. So I thought it would be helpful to highlight what we're talking about by introducing you to Alice. You can change the slide, Allison, thank you. This is Alice. Alice lived at home and she had family visiting daily to assist with her instrumental activities of daily living, things like food shopping and banking. She did experience memory loss. With regular check-ins, she was maintaining pretty well at home. One evening, she fell in her kitchen with her walker, and she happened to break both of her shoulders. The pain that she experienced from this fracture, as well as the proximity of the fractures to large blood vessels, required her to have surgery. Alice underwent surgery, and she was in the hospital for multiple days and experienced delirium. acute and fluctuating change in her mental status. Her level of function following surgery was also very different from before her fall. She was coming up to discharge, and it was determined that she needed to go to a skilled nursing facility for rehab. There were many, many questions about Alice's further care raised during both her hospitalization and her rehab stay. Could she live alone again? Would she want to undergo another hospitalization if her condition were to worsen? What would her upper body function be following her recovery? How quickly would her delirium resolve, and would her mental status be the same as prior to her transition, or prior to her fall? And with a team of nurses, physicians, therapists, social workers, and her family, there was a plan was made. The plan was updated weekly during Alice's 6-week rehabilitation stay. And while she was improving, she had many needs to consider when she was going to leave the skilled nursing facility. She still had limited mobility in her upper extremities. Her memory was improved, but not quite what it had been prior to her fall. She needed help with most of her activities of daily living, things like going to the bathroom, getting bathed by herself, getting something to eat. She could do those before on her own, and now was not quite able to do those things. And she still needed help with the food shopping and the finances from before her hospitalization. This level of care would require more than just daily stop-ins from her family. Determining this plan of care following hospitalization and skilled nursing again required interdisciplinary expertise and the inclusion of her care team. You can click Allison. As you can see, Alice was able to return home with some substantial support. And this was a success story, but not all of these situations get people back home, but Alice was able to get back home. What that required was a 24-hour nursing assistant to move into Alice's home. She continued to have home health support to assess her continued recovery and medication needs and her ability to keep her medical illnesses under control at home. She continued to need help from family for shopping and for oversight of the home health aide. In addition, Alice and her healthcare power of attorney signed a do not resuscitate order and completed a PULSE form to help guide decisions and care delivery for when she would experience another crisis in care. Again, thinking ahead of what might come next. Additionally, a wheelchair ramp was installed in her home so that she could get in and out to go to her outpatient appointments. And most important to Alice, she continued to sit on her porch daily and was able to enjoy visits with children, her grandchildren, and her great-grandchildren. Alice is one of many people that experience transitions in their care that require transitional care support from an interdisciplinary team to be able to live to their quality of life. The healthcare system and the team of professionals involved are essential at offering the appropriate level of support and guiding families and residents through this very tumultuous time. You can change the slide. So when I say transitions in care are common, they are quite common, particularly among older adults. 1 in 4 people over the age of 65 are discharged from the hospital to a post-acute care setting. When I talk about post-acute care, I'm referring to a skilled nursing facility or home health care are the 2 most common settings. 1 in 5 people over the age of 65 are then readmitted to the hospital within 30 days of that discharge from a hospitalization. So there can be multiple transitions that are occurring all at once, many of which can be quite burdensome to individuals. When we think specifically about people that are in nursing homes, roughly 1 in 3 nursing home residents experience at least one burdensome transition in the last 3 months of life. And burdensome transitions could be multiple hospitalizations within that 3-month time span, going to the hospital and requiring ICU level of care. So this is a very common situation that older people experience. requiring our thoughtful consideration of the best way to support people and the best way to structure healthcare delivery systems to deliver care through transitions for older adults, but really everyone that is experiencing this. Next slide. Some of the challenges with transitions is that you can have many hands in trying to make dot all the I's and cross all the T's, but ensuring that the communication across all of those providers and all the things people are doing can be really complicated. There's an increased risk through transitions for disruptions in the care continuity. So when there's a disruption in care continuity, we can give opportunities to miss essential care and interrupt relationships that may have been in place with care providers, families, and routines that were in place prior. There's also an increased risk for poor satisfaction for people as they're going back and forth from different settings or experiencing new symptoms and processes in their care delivery. When there's unmet needs, there's opportunities for mistakes to be made. And so there can be deleterious consequences of transitions that can result in new needs or different needs that there is not a plan to address. And so one of the most likely situations where somebody can experience the new onset of an issue are when these transitions are taking place. We also see the development of geriatric syndromes in some of these transitions, things like new onset of incontinence, new onset of cognitive changes, which are not helpful in maintaining, attaining and maintaining well-being in people as they're going through transitions. And last but certainly not least is transitions can be incredibly burdensome to caregivers who are very responsible for much of the care that's delivered, particularly in community settings, but also within care environments like skilled nursing facilities. So these challenges are places where we can design the system delivery and the care team to address some of the concerns with the number of transitions older people experience related to their health and aging. Next slide. There is significant innovation around the area of transitional care at this moment, and it's driven by many of the unmet needs and gaps that we saw on the previous slide. So we've seen significant investment in community-based supports. One example of this is waiver programs that provide additional funding to receive nursing home level support in a home setting. And so these expansion of community-based supports, both health-related services, but also social care, have been shown to improve the ability of people to age in place. Another area where we're seeing significant investment is around care coordination. The individuals, including social workers, nurses, and nurse practitioners who can assist with making those warm handoffs across care providers and settings are being invested in multiple levels. You see this at the health system level, but also funding from the federal level in paying for things like advanced care planning visits and care coordination and multiple different supports for individuals to have more focus and time around not just a diagnosis, but the ability to transition across different environments and disease courses. And last but certainly not least, we see significant growth in hospital care delivery in place. So bringing the services and the people to the setting that an individual is currently in. So programs like Hospital at Home is a program where hospital level services, often emergency care type services, are brought into someone's home. And assessment imaging can be done in someone's home to determine what to do next. While some conditions still would require a hospitalization, many conditions can actually be managed in the home, such as IV, intravenous therapy, and assessment and management to help somebody through maybe an infectious illness or a pneumonia. So what we see these hospital at home type services growing in many areas, again, driven both by changes in the way we reimburse care, but also the needs of individuals and the desire of people to be at home. Home-based primary care is another area where we're seeing, instead of bringing somebody to an office setting, bringing the services of a primary care office to the home, and providing those services and wraparound in the person's home. And we'll hear more today about the transition from skilled nursing facilities to the home, and programs that can help facilitate the smooth transition of an individual from a skilled nursing facility back into a community environment. So I'm thrilled to be here to hear more today about where we see the future of transitional care going. There has been significant focus on this for the last multiple years, and I believe we're only going to see more focus on this as we strive to meet the complex medical and social needs of older adults, but also populations that are not aging. Next slide. I'm going to hand it over to Dr. Schuler, who's going to give us more information about what actually happens between transition from the hospital to a post-acute care setting. So I'm going to hand it off to you, Dr. Schuler. Thanks so much.
Thank you, Ashley. I'm going to take a few minutes first to talk about the hospitalization piece, which is the beginning of these transitions. Hospitalization is a disruptive life event. You have the physiologic stress of whatever the medical illness or injury was that led to the hospitalizations, plus whatever interventions occurred in the hospital. You have the related psychologic stress, the uncertainty, and the worry that go along with the illness and physiologic stress. Then the impact on overall health and function. This might be temporary or prolonged or perhaps permanent or life-changing. The essence of all this disruption is change. And by definition, transitions are change. Next slide, please. Hospitalization involves transitions of location, of the kind of care received, of the providers. It occurs basically in 3 different points in time. Initially, home to hospital. Then within the hospital, and there can be multiple transitions here, for example, from the ER to an inpatient room, or maybe to an operating room, or to procedures, multiple movements within the hospital, and changing medical personnel, specialists, nurses, and other care providers. Then the third point of transition is the discharge from the hospital. So this is a lot of change, and especially for older, sicker patients, it can be very challenging and disconcerting. Next slide. So I'd like to talk about the goals of hospitalization. First and foremost, it's to address the medical problem, but along with that is to discharge the patient, to get the patient well enough to leave the hospital. Next slide. So hospital discharge planning is really a key part of hospital operations. Discharge trends have really evolved over the last few decades to shorter lengths of stay, people being sicker at discharge, needing more follow-up after discharge. And these changes have impacted timing. Discharge planning needs to start early, even on day 1. And the goal is to determine the discharge destination. Will the patient be going home or into a community setting, perhaps a family member's home, or will they need to go to a post-acute facility? And by that, I'm referring to a skilled nursing or physical rehab facility. Now, most patients intend to go home, at least eventually, but for many, that's not feasible right away. Next slide. So discussing who goes to a post-acute facility. There are multiple characteristics of who may need this type of care after the hospital. Medically complex, a lot of additional care needs, maybe monitoring of their condition, complex wound care, IV meds, management and adjustment of meds, etc. They're often older, they have less reserve and a longer recovery period. They tend to have, in some cases, significant physical changes or maybe cognitive changes, perhaps after a stroke or another catastrophic event. Limited mobility, needing to have one or more people help them to get around. Care and therapy needs exceeding what they can get at home. Even with home care and with family members being around, many people need more than that. And then the issue of home safety. If the patient was unsafe or borderline unsafe at home, no longer able to manage there very well, before they went to the hospital, then that setup probably won't work after they leave the hospital without some change. So basically, the candidates for post-acute care are those who need extra time for complicated care and recovery or for figuring out the next step. Next slide. Once it's determined that the patient needs post-acute care, the appropriate facility needs to be identified. And this depends on multiple factors. For example, bed availability and the necessary time frame. The facility needs to be able to provide specific care needs if necessary. It needs to be geographically suitable. It needs to be appropriate for the insurance and any financial considerations. And the patient and family need to find the facility acceptable to them. Next slide. So the transfer from hospital to the post-acute facility is a big transition. It's passing the baton. Next slide. But it's really more than simply passing the baton. It's a complex, choreographed process involving various people, especially on the receiving end. So it's really a combination of passing the baton and a performance where everyone needs to move in the right direction with no misconnections and no stumbles. Next slide. So getting on to the actual transfer process, this begins when the hospital medical team determines that the patient's ready for discharge and all hospital level care has been completed. Transportation of the patient to the facility is probably the easy part, but then the biggest challenge, and I have this highlighted, is the transfer of information. Actually, the highlighting didn't come through on that slide, but the transfer of information means orders for medication and care, medical records, including prior history, hospital course, and pending medical needs, and personal considerations. So ideally, whatever information is needed for the receiving healthcare personnel to take over in a seamless fashion. But in reality, this transfer process is usually less than ideal, with significant inefficiency and vulnerability to error in terms of passing all the necessary information. So this is definitely an area of ongoing need for future improvement and fine-tuning. Next slide, please. So accepting the baton and running with it. Arrival of the patient at the facility sets off a flurry of activity. Coordination of multiple disciplines, nursing, physician team, therapy team, social workers, etc. Communications and lots of them. And everyone working together to put all the pieces together to figure out how to best serve the patient. A key part of best serving the patient is identifying the patient goals, preferences, and needs, and then planning accordingly. Next slide. So goals of the post-acute facility, like the hospital, it's to improve health and functioning and ultimately to return the patient to home or to a new appropriate living situation that's safe with proper supports in place and that provides for patient and family peace of mind. And along with this discharge, the goal is to successfully pass the baton again, this time transferring the care to the outpatient physicians and other healthcare providers. Next slide. So I'll review some determinants of success of the transitions involved in a stay of a post-acute hospital in a post-acute hospital patient in a facility. First, understanding the patient's goals and needs. Secondly, coordinated interdisciplinary efforts to meet these needs. And all of these issues require communications, effective communications. And this is an area of definite need for improvement. more standardization and timely sharing of information, especially from the hospital to the post-acute facility, but also from this facility back to their outpatient physicians. All along the way, it's necessary to have thoroughness, completeness, accuracy, anticipation, follow through, basically dotting the I's, crossing the T's, and closing all the loops. And finally, everything needs to be done with the patient at the center, meaning with sensitivity, compassion, and caring. Next slide. So in conclusion, all of us who are working with a patient who has had a hospitalization that needs post-acute care, we're all on the same team, passing multiple batons in a choreographed manner, just running different legs of the same relay. With that, I'll pass the baton to Mark Tolles. He will further discuss transitions to home. Thank you.
Hi, I'm Mark Tolles, and I'm very grateful for the chance to follow these two speakers and to be with you today. I'd really like to start just by acknowledging New Cortland and the New Cortland Center for Transitions in Health, because they've been so instrumental in many of the studies and in my training that makes it possible for me to speak with you today. So thank you. As is clear from comments from earlier speakers, the transition from hospital to skilled nursing facility and on to home is a complicated series of events for a high-risk population. In the US, about 1.5 million older adults make the transition from the hospital to a skilled nursing facility every year, and well more than half of those make the next transition, which is out to home, and probably about 10% of those that leave nursing homes go on to an assisted living facility. It's a striking sort of characteristic of these patients, how different they are and how each one is so unique. And really it's the complexity that comes in, I think, trying to manage as well as possible care for people who have such varying needs and such varying amount of experience with major healthcare problems in the past, and also such wide variation in resources that are available to help them once they get home. Pretty much across the board, though, whenever we're providing transitional care for a short stay nursing home patient, we're always trying to focus on what it's going to take for them to be successful at home. And that can be very medical, like reducing the amount of pain they experience, or that can be really interpersonal, helping them become functionally able to spend time with grandchildren. A lot of times it's just trying to get back home and get back to normal, whatever normal was before the chain of events that landed this individual in the nursing home. But always we're focused on what does it take to help this single person achieve their goals when they get back home. Next slide, please. As the two previous speakers pointed out, skilled nursing facility patients or short stay patients or older adults who go to nursing homes after hospitals for short periods of time, they're very different, but they do have some characteristics in common, such as advanced age, multimorbidity, serious illness. I think serious illness is truly a signature characteristic of skilled nursing facility patients. And in just the simplest terms, I think that means that many of the problems that people have aren't going to necessarily get better. We can help people achieve greater function, have less pain, hopefully, achieve some personal goals, but some of their problems are going to continue. And there's a lot of work involved with trying to help people adjust to the most recent acute event, while continuing to manage those incurable health problems. Older adults that come into short stay in nursing homes are often very highly dependent on their family caregivers. And based on a lot of findings in research that we've done on my team and others have done, they leave nursing homes very often not really feeling prepared for everything that they're going to need to know to succeed when they get back home. Just for some more sort of broad perspective type of things, in the US, I think there's around 15,000 nursing homes, and well over 10,000 of those provide care for short stay nursing home patients or skilled nursing facility patients. And if you start looking out across the country and across nursing homes, as I'm sure many of you are aware, there's a lot of variation in the quality of care provided in different nursing homes. And this is very important because that variation in the quality of care has a lot of impact on what people's outcomes when they get back home will turn out to be. And so just a whole lot of our research and our care in this area is to reduce that variation to achieve greater equity in healthcare and achieve greater quality outcomes for the largest number of people possible. That's just an overarching goal. In research that, next slide, thank you, Allison. You know, I could go on and on about some of the numbers and stuff, but I mean, just to illustrate the complexity of care for patients when they get back home, this is a slide from a study New Cortland helped us do. We looked at 55,000 patients that discharged from nursing homes in North and South Carolina, and we saw in 30 days out of those 55,000 patients that 22% had bounced back to an emergency department or had been admitted to a hospital in 30 days, and out at 90 days we saw that it was 38%. And this was just a very, very strong signal to me and to others that, you know, there's something that maybe we can do by trying to focus on what's it take to make someone prepared for discharge. What kind of support do people need to be able to achieve their health goals when they get back home and avoid some of this type of bounce back and suffering that comes with it. Next slide. A whole lot of the talk is about the patient in the skilled nursing facility, but what's very clear in the evidence is that just the amazing role that caregivers play in the lives of skilled nursing facility patients. This is just a slide. I'm sure there's better national data somewhere. This was from a quality improvement program that we did in a few nursing homes. And in that project, the average age of our caregivers was 64. 80% of them were female. About 40% were wives. About 40% were children. And they were caring for that individual 5 days a week on average. Only half of them lived with the patient. So the caregiver is so important that in research that I do in transitional care, I just simply do not think of the patient primarily. I think of the dyad primarily. And I think that's probably a very important attitude or angle or approach to thinking about transitional care in this setting is what's the patient think and feel, and what does the caregiver think and feel, and are they on the same page, and how can we make sure that that unit is working really, really well together and that they both know what's going on. Next slide. There's been, as many of you are aware, several hospital-based studies demonstrating the efficacy of transitional care on lots of different outcomes, especially bounce backs and some others as well. We've been reviewing evidence and working in the area of transitional care in skilled nursing facilities, and from a purely evidential standpoint, there's a lot of research that needs to be done to support the efficacy of transitional care in skilled nursing facilities. So far, There's strong data from observational studies that suggest that skilled nursing facilities can provide transitional care, that it's acceptable to staff, that patients and families like it. And there's observational data as well supporting the efficacy or supporting the association between receiving transitional care and not getting readmission to the hospital in 30 days. This will certainly be a growth area in research for the foreseeable future as we learn how to do this effectively. Next slide. I think for the whole rest of my comments today, I'm going to be talking about something called Connect Home, which is a brand of transitional care that I work on, not so much because I think it's important for you to know about Connect Home, but because I think by looking at one particular model, there's just a lot that might be helpful to you as you think about how can we make transitional care better in the place where we work. With Connect Home, I think the key words in this slide are existing staff. If I read the whole little caption there, it says existing staff in skilled nursing facilities and home care prepare older adults and their caregivers to manage the patient's serious illness at home. Really, I'm very, very focused on the people who work in nursing homes or the people who work in home health care agencies and help them get the capacity to help patients and caregivers manage serious illness at home. But it's that existing resources that we have, how could we learn to use them as effectively as possible? Is really a big focus. And I think in trying to improve discharge planning or transitional care in a nursing home, it is that careful look at existing resources that is an excellent starting place. Next slide. With Connect Home, we've been working with Dr. Naylor and a number of other people for quite a few years to try to understand the unique needs of skilled nursing facility patients. And I think the previous two speakers have really taken us so far, you know, for getting a picture of what this looks like. But I mean, maybe you could think of this slide as 6 key care needs, and maybe these are sort of buckets that different services fall in. The first key care need of a skilled nursing facility patient is home safety and level of assistance. And that is, the nursing home is looking at the patient and the caregiver and trying to figure out, is there a caregiver available and trained to provide care that would assure safety of the patient after the transition home? Is the home safe? The second key care need is a surrogate decision maker and prior written advance directives. And at the level of providing transitional care services, this is not always advanced care planning. In an ideal world, I think it would be advanced care planning. But at a minimum, there should be 2 things that are done. One should be to find out if there are prior written advance directives and to locate any kind of paperwork that's associated with those prior written advance directives and get it together and make sure the patient and the caregiver understand it and know where it is. The second one is much easier, and that's a simple question that can be asked of a patient to say, if something were to happen and you were not able to speak for yourself about what you would want done, who is that person? And then begin to try to get that documented. And if necessary, that is the springboard into a conversation about advance directives that could be started with that simple question in the SNF. A third key care need of skilled nursing facility patients is symptom management. In my experience, this is a difficult thing to achieve. It requires a great deal of effort when you're trying to change practices to help patients and families with symptom management. It requires nurses and physicians and nurse practitioners and physicians assistants who have the know-how and the time to talk with patients and caregivers about how to take care of illnesses at home. And that can range from anything from management of pain, management of dyspnea, management of sleep problems, wound care, diabetes care, just a whole range of congestive heart failure with all that goes on with the meds and the weighing and the breathing and just the suffering that goes with that. How do you manage those symptoms? And who in the nursing home is talking with the patient and family about managing those symptoms? There's a lot of work that goes into meeting that key care need. The fourth key care need is medication reconciliation. In a nursing home, medication reconciliation is it's complicated at times. I'd say if you're really starting out and you're really trying to think, what can we do about this? A great place to start would be to ask, are you able to reconcile the medication list there in the nursing home? Maybe it will not be possible for you to figure out all the medications that changed in the hospital, but can you create a medication list that is accurate on the day of discharge from the skilled nursing facility to home or the assisted living facility? That is a fantastic place to start, because then say you have a patient in the skilled nursing facility who's going home. If you can produce a reconciled list at that moment, that can go to primary care, that can go to home care, and that can go to the patient and caregiver at home, with all of them on the same page, at least for where you were in that moment in time. And that would be a wonderful start. And frequently in quality improvement, et cetera, that's where I start with nursing homes. The fifth key care need of patients at the time of discharge is understanding how to do a transfer, how to walk, how to prevent falls. Those are just enormous. And if there are any occupational therapists in the group out there, I didn't mean to leave you out at all when I was focusing on walking and transferring, because there's so many other things too that have to do with function, which is getting to the car, getting in the tub, being able to do some things for yourself. So occupational therapy is right there with it. I emphasized transfers and falling because falls are such a big deal when patients get home. The sixth key care need for patients in nursing homes, as I'm thinking about it, is coordination. And some key components of that would be to try to get home care there within 24 hours. To try to make sure that your paperwork from the nursing home is available to home care when they come in, and to make sure that all patients who discharge from the nursing home have a scheduled doctor's follow-up appointment for when they get out. And hopefully within 7 days, if that's possible in the communities where you work. Next slide. Oh boy, I realize I'm not going to be able to go into the same level of detail, but I feel like the key care needs are important. This slide, what's important about this slide is that we've gotten Connect Home to the point to where I can teach people to provide transitional care in 4 steps. The key takeaway from this slide is that when you're working inside of a nursing home, you're always working with an interdisciplinary team, working with lots of patients. So when you introduce transitional care, or you begin to improve the quality of transitional care or discharge planning, it really helps if you can teach the staff, okay, we're going to do this in 4 easy steps. Step 1, we're going to do this. Step 2, we're going to do that. Step 3, we're going to do something else. And I'm not going to go through every word in this slide, because I think the key message is trying to figure out, what are your steps? What is our care path? And what areas are we good at our care path? And what areas do we need to work? For example, in this diagram is a care plan meeting with patient and caregiver. Great questions to ask about that might be, are we having it in the first 72 hours? Are we having it in the last 72 hours? Are we having it in the middle? When do we do it? Who's coming to the care plan meeting? How long does it last? Who's the leader? Does nursing ever speak up? Is a social worker doing all the work and we're making him or her do everything? There's just so many questions you could ask about each of these steps. And I'm excited to see COVID go away for lots of reasons, but One reason I'm excited to see COVID go away is so we could get back to some of these basics in our discharge planning services and look at these steps and make sure we're doing them right. Next slide, please. My point with putting this up here with intervention supports is to say that if you're going to try to address something like the 6 key care needs, and you're going to say you're going to use a 4-step process to do it, it's not enough to train the staff. So many times that I have heard either people I'm working with or students I'm training, or just in lots of situations where someone has the belief that if I can tell them about transitional care, they can do it. And in my experience, it takes more than that. First off, there really need to be some tools that are provided. And key ones might be, what does our discharge summary form look like? Most nursing homes have an EHR, and in that EHR, they have some kind of discharge summary template. Well, has that thing been modified in the last 5 years, or is it patient-centered or is it clinician-centered? Because it should be patient-centered. It should be designed to create memories and resources for a patient or caregiver. Other tools are the care path, like I was speaking of a moment ago. Other tools might be a protocol to say, okay, this is how we do it. Of course, training is very, very valuable. Retraining is very valuable. Like, are you having something like a monthly PDSA meeting, or a monthly meeting where people says, wow, this is terrible, or this is great, or you did a good job, or I wish you had done a better job, and maybe morbidity and mortality rounds in a building to talk about cases that went really well and cases that were a big struggle, and talk about discharge planning. As I look at this slide, I kind of feel like I want to tell you that discharge planning and transitional care in a nursing home should not run on autopilot. It's, all of these tools, training, and technical assistance, what this is all about is how to be proactive with making sure that the quality of care is awesome. And what kind of tools do you need in training, and what kind of supports do staff need to make that possible? Next slide. Next slide when possible. Oh, thank you, Allison. I think I'm beginning to move towards the finish line of my talk. I might have a couple more for you. I put this slide up here because this picture means a lot to me. This was a group of staff that came in from several nursing homes in the Midwest to work with us. And they were going to participate in something like a year-long project with me, and to work out in their different nursing homes to improve quality out there. And I'm showing you this slide today because when I worked with this group of people, one of the things I took away from it was sort of a change in mental model that we were working on with them to sort of get them to be able to go home and take it back to their staff. And that's this point. A lot of time, the people who are working inside of nursing homes have so many problems and so many patients that they're trying to take care of that they tend to focus on care inside the nursing home and patient needs inside the nursing home. And that when you're working with a nursing home to try to help it improve the quality of discharge planning or transitional care, a huge chunk of the work is having staff ask the question, what do we need to do to make sure that the patient and caregiver are ready for the first 2 weeks at home? You're really trying to shift their mental model to think about that first 2 weeks at home as opposed to just what's happening inside the nursing home. And the more that you're able to help people understand that shift in mindset, many of the other things that we've talked about today about care or transitional care in the nursing home gets a lot easier, because then people can start using their intuition and their common sense to work towards that goal of patient and caregiver capacity for care during the first 2 weeks at home. And so this was, I don't know to what degree the picture is relevant to that point, but I really hope that you will take that message with you from my remarks today. In fact, I would say that this is a great place for me to stop and say that I hope this has been helpful, and I'm sure my colleagues and I will be very happy to take your questions and comments. Thank you.
Thank you, everybody. We do have some questions here in the chat box. Actually, a lot of questions, which is great. The first one is, do you see technology playing a greater role in transitional care? Whoever wants to take that one.
I'm happy to take a stab at that one. I believe technology gives us the opportunity to see residents across settings, which can be really valuable. You know, if you think about a nursing home, getting specialists inside nursing homes can be very difficult, and transitioning somebody from a home environment into a care office is very difficult as well. And so there's great opportunity to have high quality touch points through technology to see people and to assist in their care coordination and their transitions. But that all comes with sort of like with great power comes great responsibility. Older adults do want to engage with technology. Many of them don't have the resources to do that. And so there's equity issues that come into play with using technology when there's not an alternative to see in person. And the other is that social isolation among older adults is a challenge. And so doctor's appointments for some people are one of the only times that they get out into the community. You know, so if you replace social work visits, you know, any substance use meetings, primary care visits with a telehealth appointment, there's sort of some consequences around isolation. And so I think the thoughtful uptake of telehealth can be incredibly helpful in increasing connectedness, meeting needs, and eliminating some burdensome transitions. But we have to do that in an equitable way and realize that it's not the cure-all.
Wonderful, thank you. And the next question is, how are you addressing the hospitalization stress that affects the family and primary caregiver?
I think that one of the key ways of helping people deal with that stress is to talk with them about their expectations of care, and to really ask a family in a care plan meeting or an assessment what it is that they really hope to achieve. And as quickly as possible, get care focused on people's preferences and their goals. And then they can find in doing that with you that you're willing to understand how they're unique and what their loved one needs and hopes for the most. And that, I believe, is just powerful, because that leads to the best outcomes and it builds trust at the same time.
In my experience, helping them understand what's really going on is important. Many times at the hospital level, everything is so new, maybe a new diagnosis or complicated medical issues that they don't really have much understanding of. And people learn this, develop an understanding incrementally. So I think just continuing to be available to answer questions, to share additional information, to help put their minds at ease, or just to help them understand what they're dealing with.
I agree with both Mark and Mary. What I would say in addition is that we need to, one of the best moments to ask questions around hospitalization and what you might want next is right after a hospitalization. So having a moment to reflect upon, you know, how did that hospitalization go? What went well? What didn't go well? How can we think about what we want in the future? It's really a powerful moment to talk about what we expect moving forward and how we can meet the person's needs. I also think in terms of the future of care transitions, so much of our reimbursement system is built around this hospitalization. So, when you go to the hospital, that's sort of the way to get skilled nursing services paid for, both in nursing homes and in home health in many situations. And so I would love to think more about how we move services upstream to before that first hospitalization and start talking about it before we get into that crisis situation.
Thank you, Ashley. Another question is, the experience of patients and their caregivers during the COVID-19 pandemic have suggested opportunities to enhance transitional care. Can you reflect on how we should capitalize on these opportunities and achieve essential improvement?
That's a loaded one. There's so many things around that. I think for me, what I have noticed and what has hit me the hardest is, nursing homes don't function in isolation. There are people that come in and out of nursing homes to help to deliver care, and a huge part of that care and the quality of life for individuals is their family. And so, I think this has forced us to think about how nursing homes are really nested within communities, and we need to make sure that those doors are open and that there are pathways for people to come in and out, and there are ways for people to be engaged within and outside nursing homes. They're not a separate entity, and they can't be, would be my takeaway from COVID.
I guess if I had to say, it seems to me that it's not fair in my eyes how many Black people died compared to how many white people died. And I was just horrified every single time I heard that. And so I feel that it really raised equity in my eyes, and I wish that I could just suddenly make that better. And I know that that's a big change that we have to work on.
It's a great question. Joe DeMayo here. Behavioral health challenges have historically been a tattoo subject for nursing facilities, either not admitting an individual with a history of behavioral health and allowing behavioral health providers in the facility. Now, with many opportunities with services that are allowed to go into the facilities, how can nursing facilities change their stance on this topic?
I believe that facilities are more and more, from what I've seen, having trained personnel within their facilities to address those issues in more depth over the years. So I think that trend needs to continue, in addition to allowing in the consultants from outside.
I also believe that I agree with Mary 100%. There's a need to ensure that the psychiatric services in nursing facilities are reflective of the needs of the people inside nursing facilities. So, I do think that in our future, we will see the need for substance use care within nursing facilities. It's very hard to find a nursing facility that can also treat substance use disorders. We need integration of those behavioral health records. If you're thinking about transitions, we don't want people to live in nursing homes if there's a way for them to be sustained and functional outside of nursing homes. So those behavioral health records from nursing homes need to get back into the community. The way that reimbursement is structured in many ways, behavioral health services are a consultant service. They're not integrated in with primary care, nursing home, primary SNF delivery. And so if you don't have access to those records, and those records can't be transmitted outside of the facilities, it's really hard to provide continuous care from the transition into the facility as well as the transition out.
Perfect. We have Susan Russo from Nazareth. Susan, you want to ask a question?
No, I just want to add in that we have several skilled nursing facilities that have transitional care nurses, and they've been doing a wonderful job transitioning patients with meds and appointments, and really transitioning the care from the SNF to the home setting. They've been doing a great job, and you know, I work in that market, so I just wanted to add that in. You know, making doctor's appointments, I think we find that the PCP appointment is vital. You know, when the patient is discharged from SNF, getting that transitional care appointment immediately within 7 to 10 days, and then any follow-ups. You know, we have lots of services here in our accountable care organization, behavioral health, and I think it's very helpful. So I think with the SNF, I think the model of having a transitional care nurse is extremely important.
I agree with that, and having been on the receiving end in the community as an outpatient primary care doctor for several years, I think it's so important to have that timely appointment, as well as proper transmission of information needed by that physician at that appointment in advance, not when the patient shows up and doesn't
Correct.
remember anything, or after the patient shows up. It's really important to have that timely flow of information. And I referred to that in the passing the baton to the outpatient care team. So important. So I really agree with the coordination with the primary care team, or else you are at higher risk of bounce back to the hospital and other consequences that you are trying to avoid.
Thank you, doctor.
Any other questions from the group? You might be on mute, so please unmute. We do have another question from Bob Haley from Kindred Hospice. With so much care planning revolving around the hospital mission, do you think forming a collaborative agreement with community partners like what Germantown Home is doing can help impact readmits, goals of care, and management of chronic illnesses?
Yeah, I think that agreements like that can be extremely powerful with lots of populations of patients. I worked for a long time in a project that was really designed to help individuals at risk for homelessness, and it came with a project that was through a nonprofit in a hospital where we were working very closely with their discharge planners and then working with individuals in the community, all because of that type of practice agreement from the hospital to the nonprofit. And it was a very effective model. I'm sure it happens all the time in different settings.
I would agree. When you have multiple partners with different skill sets, your sort of bag of tools is expanded, and you're able to pool resources from a number of different providers, all with different expertise, to provide the best plan of care for those individuals. And I think the other is that, you know, we talk a lot about the needs of individuals. All of these individuals come with enormous strengths. And when you have communities that can, you know, capitalize on both the strengths and the resources, you're able to serve a larger group of people and create a lot of meaning in those communities. So I'm all for that.
Awesome. Any other questions? I think we are a little bit past the time. I do have some other slides here available from Mark Tolles under the handouts. If you do go under handouts, I do have the presentation that we had seen today. I also have handouts regarding Germantown Home and New Cortland services and programs. And we have two other events that are coming up with the New Cortland Center of Transitions and Health. Do Well by Doing Good, conversation with Bill Novelli, which will be moderated by Dr. Mary Naylor on Wednesday, March 31st. So I'm happy to send that. If you reach out to me, I can send you more information about that. and also for a very important discussion with panelists regarding social isolation and loneliness in older adults on Tuesday, May 11th. So please register for that one as well. You can also go onto the New Cortland Center for Transitions in Health and register through there. But just want to thank all of you, Dr. Tolles and Dr. Schuler and Ashley Ritter. Thank you for a really informative discussion. As we know, transitions in care is, increasingly important with all the work that we are doing, whether that's hospital to home, SNF to home. So thank you so much for this. This is, again, has also been recorded, so we will add this to the New Cortland website and then share the link with anybody that might have missed the call. So thank you so much, everybody.
Take care.
Thank you.